Professor Forde, and thanks for your outstanding speech. So for me, I'm the last one to discussion. So I have two quick questions about the new adjuvant therapy. One is for maybe the oncogene mutant negative patients. That's we use the IO combined with chemotherapy to get a high PCR rate for some or for all the clinical trials that we get good results for this. But in our experience, not all patients will get PCR, of course. So maybe 20 to 30%, that is a good result. But for other patients, should we do more cycles of the new adjuvant IO plus chemotherapy, or we just stop as the clinical trials for 3 or 4 cycles? If they cannot get MPR or PCR, that's enough for the or new adjuvant treatment. That's one question. And another one is because in our department that we do chemotherapy and radiotherapy together. So I know some maybe small samples of clinical trials that they try to combine with some short times, that's the radiotherapy, like 8 grays play 3 days like this, to do all the new adjuvant treatment too. So what's your opinion about all this combination of the method to treat patient? Do we need stronger like this radiotherapy, chemotherapy, immunotherapy together, or we choose patients to do so, or we longer the cycles of all these patients? Thank you so much.
No, thank you very much, and I think those are very insightful points. To your first point about the duration of the chemotherapy, my personal feeling is that probably 3 cycles is enough. If you look at the PCR rates from Checkmate 816, PCR was 24% from 77T. With 4 cycles of treatment, it was 25% from Keynote 671, 18%, and the GN about 18% as well for 4 cycles. So I'm not sure we're seeing higher PCR rates with more chemoimmunotherapy in the neoadjuvant setting. I think if you can get to the 3 cycles, that's probably enough, and you may potentially avoid some more surgical issues by going to surgery a little bit sooner. So for me, if a patient can get to 3 cycles and they're still feeling well and doing well, I will be happy enough going to surgery, and I don't think we gain too much by prolonging treatment. And I think what's going to be interesting in the longer term is, can we predict which patients are not having a PCR by ctDNA potentially? So from the Aegean trial, they had nice data, as I mentioned, where if you did not clear ctDNA, you were very unlikely to have a PCR. And that could be a situation then where maybe you change treatments. Maybe if you have a targeted alteration, you change to a targeted therapy. Maybe if you have an ADC, you think of using an ADC. I think the NeoCOAST-2 trial as well, the one that I mentioned earlier, where with the use of a TROP2 ADC in the neoadjuvant setting with chemo and durva, we see the PCR rates going up to 34%. That could indicate to me that while ADCs may not work very, very well in pre-treated disease, so in more advanced late-stage disease, perhaps they will work better in the neoadjuvant setting. And I think it's worth exploring that further in clinical trials. And to your second point, I think in terms of the sequencing of radiation with chemo and immunotherapy, as you noted, there have been 2 trials, at least in the West, and probably other trials as well. There was a Dr. Al Torki in New York did a study of kind of very kind of what he called subablative radiation along with chemotherapy and durvalumab, and that showed quite good results. Whereas in the Netherlands, they had a study of chemo with ipilimumab, nivolumab, radiation, And that also showed results, but quite a lot of toxicity. Personally, I would like to see further radiation studies in this setting because I mentioned in Checkmate 816, the impact of chemoimmunotherapy was mainly on distant recurrence. So you're still seeing a lot of local regional recurrence. And my hope is that might be addressed by further radiation studies. I just don't know when that radiation should be given. Should it be during the neoadjuvant setting or should it be post-op? And I suspect personally it might be better given post-operatively. I think we may need to readdress the question of, for example, the long arc trial for N2 disease or for high-risk disease. Are there more intelligent ways we can give radiation in the post-op setting to reduce that local recurrence rate?
Thank you for your sharing these opinions. We have tried some clinical trials in our centers. So that's before the chemotherapy or after the chemotherapy, we try both. But for now, that's quite small samples. It's only 10 patients enrolled, and we got 6 patients undergo the surgery. And these 6 patients, I guess, yeah, these 6 patients, they do IO plus chemotherapy first, and then we do the radiation for the 3 times, and then they all get NPR. And the PCR rate get, I think, 4 of 6 patients. So maybe that's a good way to try that we do the radiation after or post the chemo with radiotherapy, chemotherapy with IO. Yeah, that's maybe a good way. Thank you for your sharing.
So we have all the 5